Welcome to the Liver Lounge, your go-to podcast for the latest updates in hepatology, featuring discussions with the world's leading experts.
Thank you so much for joining us, Elizabeth. Could you just briefly introduce yourself to the listeners?
Sure, absolutely. So I'm Elizabeth Lee. Most people call me Liz. I'm a nurse practitioner at Toronto General Hospital in the liver clinic at University Health Health Network, and it's located in Toronto, Ontario, Canada. So briefly, I work in an area managing many patients with decompensated cirrhosis, actually, most in the post-discharge setting. And through that, I've actually come to appreciate a lot of complexities are involved in the care, both from a medical perspective, but also from a psychosocial perspective. It comes as no surprise that the leading etiology of the patients that I do see is alcohol, probably about 50% or more. And so for me, this interest came out of the work that I do. It did come with a little bit of urgency because of the fact that a lot of our patients are sick and do require some type of intervention. And this is really where we found what's really lacking in our service. And I've really come to become interested in alcohol-associated liver disease as a default, really, because I think it was more of a necessity than anything.
Right.
Yes.
What do you think of the changing epidemiology after COVID? Has it really significantly increased the amount of patients with alcoholic liver disease?
Yeah, absolutely. I would definitely say that we've definitely seen that in at least our hospitals. There hasn't been specific data from our center, but in looking at some of the other Canadian centers that have looked into your data, I think over the course of the pandemic, and especially even after the first year, once COVID had started, you saw that there was doubling of hospital admissions related to alcoholic hepatitis and alcohol-associated liver disease. And so that was also, I guess it didn't come as an entire surprise. I mean, intertwined in a lot of the conversations that were had was really also around mental health, substance use, and also a lot of people avoiding first presentations to hospital just because of the fact that COVID also was going on. So I think that there was a lot of that was happening. I think that there was still a lot of effects that are happening post-pandemic. The economy hasn't really quite recovered. I think that for a lot of people, COVID represented an era that was really quite stressful. And I think that there's still a lot of disentangling from that. So I think for us, it's just a growing awareness of the importance of really supporting some of the other issues that a lot of our patients are having in order to really tackle alcohol-associated liver disease head on.
Right. I mean, if we talk about an individual with alcoholic liver disease, what do you think are the major challenges that they face?
Well, I think that that's a good question, actually, because I think that's actually a bit of a twofold problem. So, I think that there is the addiction piece, and I think it's important to recognize that that is real for a lot of people, and recognizing that as a medical condition that might require therapy. The other part of it is looking at it from a psychosocial perspective. I think that what is underlying a lot of it also as well is being able to address some of the psychosocial factors. Like a lot of people, and that could be cultural, that could be through an economic background of like precarious employment. But having said that, though, we do see a lot of diversity in alcohol-associated liver disease. There are also a lot of people of other backgrounds like that are perhaps a little bit more affluent that also do struggle with alcohol-associated liver disease too. And that's why I do want to really highlight the fact that I think it is both like a psychosocial piece, but also I think that there is a lot of a cultural component also as well.
Okay. And in your center, how does a patient with alcoholic associated liver disease,
Alcohol-associated
alcoholic
liver
use
disease.
yeah,
Okay.
yeah. Nomenclature has changed recently more of alcoholic use disorder. Yeah,
Mhm.
how are they being managed in holistically in your center?
Yeah, well, I think that we are still learning how to optimize that and how to still do better. I think currently right now for a number of our patients with alcohol use disorder, for those that, and I'm going to talk about it a little bit more from the patient population I do see, which is a little bit more advanced. But I will briefly talk a little bit more about those that are being assessed for a fibrosis assessment, like that are being sent in by their primary care providers. So I'm going to just separate the two. So for those that have alcohol-associated liver disease and with pretty advanced disease, there is a bit more clinical urgency in the sense where there is a lot of interconnectedness between their alcohol use and how sick their liver is. And so in our center, I must say, it's still difficult, I think it's come from having a lot more awareness around and familiarization around some of the pharmacological therapies that are used for treatment of alcohol use disorder, understanding what pharmacological therapy could be used in the context of someone with more advanced liver disease. Because what often is the challenge is that when we do send them to our addictions providers, they do get pretty worried about the person's liver. And it actually ends up being a little bit more of there is some delay in treatment as a result of trying to understand the context of the liver, and people often actually become very undertreated for their alcohol use disorder because of needing to strike the balance with someone's liver health. So I do think that there is a role for a liver provider to play in terms of having familiarity, being able to support our addictions colleagues in order to really help with really supporting in the treatment, pharmacological treatment for alcohol use disorder. There are also non-pharmacological therapies also as well. I think that one of the things that is really key, and we often use brief intervention as a framework for discussion for a lot of our patients in practice. And this is well described, and it actually uses something called frames. That's actually the framework. But through that, it really helps us with understanding where our patients are coming from. Do they understand what is happening with them? Are they ready to make change? And also having some familiarity with the referral services that we could refer individuals to is also really important, because then the next part of it is then being able to link them to referral to an appropriate service. And so we work more in the collaborative model with a lot of our partners. We don't necessarily have an addictions provider that is specifically focused to our practice. However, I think through our work, we have developed a lot of collaborative relationships that really helped us with linking people to care. So that's that. Briefly speaking about the individuals that are probably on the less sick side of the spectrum of chronic liver disease with alcohol-associated liver disease. In terms of those individuals, I think the framework, and I think part of them is getting them to first understand that they are drinking and consuming alcohol at a level that is at risk or high risk. And I think in terms of pharmacological therapy, similarly so. In terms of those individuals, I think that there is a bit of a spectrum. Some people just want to check in and they know that their liver technically right now is okay, and then they'll want to check in again, right? That's really it. So there, I do find that the engagement in that particular population to be a little bit lower, but I think it's more about, can we get some high level pieces? So, and we try to make it really intentional, like the meeting very intentional. So instead of don't drink, but it's also about, so if someone is stepping in the door, it means that they want help of some sorts, they want some kind of information. So for us, it's about then meeting them where they're at and then providing some meaningful guidance back to their primary care providers. So that way, then we could continue on with supporting these individuals as well. So a little bit of a long-winded answer, but hopefully that helps us sorting out the two spectrums. Yeah.
Yeah, that's great. I'm just wondering, like in Canada, how do patients get referred to your clinic? Like from the
yeah, so in general, or just or specifically in my practice, because there are two different facets to it.
I think both will be great. Like in general.
Okay, sure. Okay, sounds good. Yeah, so in general, so the mechanism for referral, it could come from a lot of different places. So comes from typically a billing provider, so a nurse practitioner or a medical doctor. And that could come from either primary care, it could come from a specialty service coming through the emergency department. So these are all relevant and relevant in terms of understanding the context of how they got referred. But that would be the primary mechanism of referral. And then they are then triage by clinical urgency. And then it could be any of the medical providers that include myself included, that are part of the consult pool that do come to see specific patients. Yeah, so that is that's the general referral pool. In terms of the patients I do see, especially those with decompensated liver disease, especially when I'm seeing them after they've been discharged from the hospital, typically those are individuals that have been seen on our hospital consult service, have been identified as requiring close monitoring and follow-up and linkage to care within 1 to 2 weeks post-discharge. And that's how they were then referred to us. So as a nurse practitioner. So I do have a second nurse practitioner colleague that also does similar work. And so the two of us help with supporting our patients with decompensated cirrhosis in this particular setting. Yeah, so those are the two mechanisms for referral here. Yeah.
Okay. And then once they arrive in the clinic, like what happens? Like how do you encourage them to abstinence?
Yeah, well, I think part of them is to have them actually understand the scope of the problem. So I think the first part of the conversation is even just an understanding where they're at. So I often start off my conversations with, do you understand what is happening with you? So I do ask that. And I think a lot of people worry about asking an open-ended question because you're not prepared what's on the other end of it. And that could be a long-winded answer too, right? So there is some fear in opening up that can of worms. But it is amazing how much information you get from just asking that. You immediately get an understanding of how they understand how sick their liver is, but you also get an understanding of what may have caused their liver to get so sick, because then that opens up that second conversation also as well, that's more primarily focused on their alcohol use disorder. And so I think it's really important to make that linkage, especially, and that might take a couple different times also as well, even in having their their family members or who they call family hear it also as well, I think is important because it helps with reiterating that message. In terms of achieving abstinence, I think it really depends on how you frame it in terms of it being something that's high stakes. And so it is a different conversation for patients who are sick. They do need to understand that there is a specific commitment behind the abstinence factor, particularly if it precludes them from being eligible for treatments like liver transplant. So it is important to also make that linkage. For a lot of individuals, that is enough fire, to set that stage for them to really understand that it's really important to cut back. I really do need resources. For the criteria for our liver transplant program does require not just a period of, it's not really defined abstinence, but it's more about assessing risk of relapse. So, and with that, they also want to understand someone's engagement in relapse prevention. So that itself is a little bit more of an easy sell for some individuals, because then they understand the scope of their problem and understand that it's time and they do need help. And that's what leads to then better conversations around linkage to the rapid access addiction medicine clinic, another addictions provider. So that's part of it. And then also the pharmacological therapy that we do often prescribe upfront also as well. That's also part of supporting someone's abstinence as well. So that's sort of in a nutshell of how we help with supporting someone getting to abstinence. and I think that's where I'll leave it for here for now. Yeah. Mm-hmm.
So I mean, from your point of view, what are the things that we can do to like improve the management of alcoholic use disorders? This is often often an population that people do have difficulties with, especially in the management. How do you
Yeah.
suppose we can, provide, how can we provide closer monitoring and or provide better management for them?
Yeah, that's a good question. So, and so I would say that, so maybe I'll start off here by saying that it's so for in order to really support someone with alcohol use disorder or any type of addictions, and I think that part of understanding a little bit around, I think some of the addictions framework also as well. And some of my addictions providers, if they hear this, they may call me later and say, "No, Liz, you're actually wrong," but that's okay. But I think from what I understand is that in terms of understanding, if the longer you're able to support, like to have a longer period of time with abstinence, the more likely that they will continue to abstain. So if you are only following someone for a period of 3 months, that's a bit of like a danger window period. So that's only one marker of success. It's really more also about then how you support them 6 months out, a year out. And I think that sometimes we forget about some of these other time points within the time frame of checking in to see how their liver health is. And because we do often see in Chang, I don't know what it's like in Singapore, but I definitely have seen in my experience here for some of our patients, they abstain, and especially in the first 3 months, they feel a lot better, and then they relapse to alcohol. And that's what I've come to also realize is an important part of, I guess, what we could potentially call as aftercare, in the sense where it's also as important during the period of time where they're most engaged, which is typically during the period of time when they're most sick, that you're also having these concurrent conversations around connecting to relapse prevention, but also introducing conversations that as you feel better, it's really important that we do think about some strategies that help with supporting relapse prevention. So because you might be then integrating back into the workplace. You might be in a setting where you're exposed to alcohol because of it being around you socially. What are you prepared to do? And those are actually also really important conversations in terms of supporting someone along the trajectory of abstinence. And so, because it's also about being able to frame those conversations, so that way they do continue to think about developing tools in their toolkit in order to support their liver health concurrently.
Right.
So that's what I would say. Yeah.
So I guess it's a lot of interpersonal relationships with the patients that might push them towards more of the abstinence path rather than relapse. I'll just think here, but do you know any things we can do like adjunctly to help them on this road to better liver health?
Yeah, well, for sure. So as I had mentioned in the beginning, like I think I've come to appreciate there are a lot of complexities to liver health. And I think that especially as a nurse practitioner, I would say that, and I think not just as a nurse practitioner, but I think for all of our medical colleagues in general, I think that it is very relevant that to treat someone's health is also to look at it holistically, right? And so I think that in order for us to be successful, particularly in this area, is really also thinking about the things that might impact someone from being able to make choices, and maybe not to frame it as specifically choice, but specific actions that may impact your liver health, like relapse, right? So I think, like, first and foremost, it's unbelievable the power that you hold as their liver provider. They'll listen to their liver provider over a lot of providers, actually. And so you do actually play a really important part in that engagement piece. And I think it's really important, first and foremost, to be empathetic and non-judgmental, and just being there sometimes is really an important part of it. And you may think you're not doing very much, but you're actually doing a lot more than you actually think. And patients will tell you that. Like, sometimes patients will tell you that they're just glad that there was someone in their corner to help with supporting their health, and they will check in. And I think that if you build a culture of accountability for your patients, they will check in more than you think that they will. And in terms of other things that really help with success also as well is really understanding your local landscape. So I couldn't tell you, Chang, in Singapore where the resources are, but I think that it is important that you do, in order to be successful, is that you do understand what is happening with your colleagues, who are the right colleagues to have in your corner, or maybe it's about reaching out and building that network of connections. So over this period of time, it's been a lot of network building also as well. So if I do need some supports, or if they live in a certain geographic area, I can make that and facilitate that referral and make that call, right? And so I think that those are some of the other important factors that allow for you to be successful. The last part, and this is obviously wishful thinking, and is really more about how to build it up more from like a multidisciplinary service. I think we've heard about a lot of successful models, like, including like hearing about at University of Michigan, where like Jessica Melger's group, and there are other models like that are propping up. And I would say that, when we do think about like a psychosocial team, like one of the things that we have been excited about, and I think has been of huge impact to a lot of our patients, is also the integration of what we call a community health worker, which is like a social worker, and where they can also help with supporting a lot of the psychosocial factors. Because, for a lot of our patients, the reason why they may return back to work early is because they're suddenly unemployed for the first time. They have no means of being able to pay for their medications, and to be able to also support some of those other pieces around making sure that they have drug coverage, making sure that they don't lose housing imminently. These are also important pieces that are as relevant and will keep someone engaged in care, because it's also about helping and supporting some of these other factors.
Okay, great. Thanks so much for your lovely insights. I think it's very eye-opening. I think the hearing from our colleagues from the other field really helps us to think from what we are missing. And thank you so much for sharing this with us. I think it's been great reflection from our part. So I think that comes to the end of the interview. I just wanted to check, is there any things you'd like to say to any other pathology colleagues around the world?
Sure. Well, I should probably have started with this, but I just had wanted to say thank you very much, Chang, for this opportunity of being able to connect with our liver community virtually, to talk about a really important topic. And I think for an area that is so predominant in our practices, I think that there's conversations that are few far in between. And I think it's really important that we do continue to build the momentum and build the toolkit, so we could support our patients and keep people healthier longer. And I think that liver providers have a huge role to play in this area, in this field.
All right, thank you so much for your time.
We have come to the end of the episode. Thank you for joining us, and stay tuned for more captivating discussions.